Morning, everyone.
Morning.
Good morning.
We have a reasonable number. We'll wait about a minute or two and get going. I guess we may as well get moving. Okay, so I see our resident Mohammed is here with us this morning. Welcome, Mohammed.
Thank you.
What do you think? What kind of pacing is this in this patient? Is this single chamber, dual chamber? What do you think?
Looks like a dual chamber pacing.
Okay, and what is going on in the atrium and what is going on in the ventricle? Do you think?
There seems to be, looks like there's a block there with a prolonged PR interval.
Okay, PR is on the longish side.
Oh. And there's also prolonged QRS with.
Why is the QRS wide?
Probably it's a ventricular ectopic.
Well, the question at the top of the screen says, what is the type of pacing? So that should give you a hint that there's pacing on this tracing. And you yourself said you thought it was dual chamber. So what chamber is being paced?
The ventricle.
Ventricle. And what chamber is, and what's happening in the atrium? Is it being paced or is it being sensed, right? Because that's the two things that a pacemaker wire can do. Can either pace or sense.
Seems like A is being sensed.
Right, so we would call this A-sense V-paced rhythm. So this is synchronous pacing, and you're right that the PR is a little on the generous side in this case, and probably it's because whoever programmed this pacemaker set the PR or the AV delay a little bit on the long side, although it's not terrible. I think the PR is just a little under 200 milliseconds, so it's probably an acceptable amount. And now let me ramp this up to a higher level question. Let me ask Dr. Duong. Dr. Duong, do you believe that this is unipolar or bipolar V pacing in this tracing? Can you tell? You can also say you can't tell. That's an acceptable answer if it was true, of course, which it might be, but it might not.
Okay, so unipolar versus bipolar pacing.
And just so everyone's on the same page, right? Normally in 2022, we would almost always bipolar sense and pace everybody. Remember again that in a bipolar system, the electrodes are on the tip of the lead, both the cathode and the anode. And so they're easy to, so the stimulation and the sensing is between a very small distance, typically 2 millimeters or so, whereas in a unipolar system, typically there's one electrode at the lead and then the actual pacemaker itself is the other electrode.
Yeah. So, I mean, the one thing that I can think of is kind of this, maybe the size of the pacing spike. So I do think it looks, they kind of look larger than I'm used to seeing. So if I were to guess, it's a unipolar, but I'm not sure you can tell.
Okay, I'll give you credit for that. It's hard to tell, but this is actually bipolar pacing. So This is just for whatever reason. It could be, well, actually here it says that it's 10 millimeters per millivolt, so it's a little bit higher amplitude. So the signal is a little bit wider, a little longer, but you see in some leads you almost can't see it at all. Like
Oh, I see.
right?
Yeah.
So when you have unipolar pacing, because the distance between the cathode and anode are so large, and the electrons are being transmitted between a very large surface area, it's very common that you see a very large pacing spike. Now, the only thing I'll remind everybody is that when we're in the ICU, if the ICU monitor has been programmed for so-called pacemaker mode, the system will look for a high frequency signal such as a pacing spike, and it will augment it on the screen with the intention of making it clearer for the observer what's going on electrically. My personal opinion, and this was a fight I had with Dr. Ofori, Imamfo forever, and also with Dr. Aiden. I think it's very confusing, and I think that the reason I think it's confusing is because when the signal becomes very small, the computer will sometimes not be able to see it and will not augment it. And the people at the bedside are erroneously fooled into thinking there is not pacing because of the absence of these augmented signals. So I would just caution you when you're looking at a monitor signal. But in a regular 12-lead surface electrocardiogram, as this one is, this is actually a bipolar pacing and sensing, which of course is not going to create a spike. So thank you there, Sonny. Okay, let's move to the next. Oops, that was the end of the slideshow. No, that was not the. All right. Okay, well, let's look at this one then. So following up of that, let's go to Dr. Perna Bonsall of Florida. Dr. Bonsall, what sort of pacemaker program is here? And do you think this, well, let's start with that. Is it single or dual chamber pacing?
Good morning, Dr. Paz.
Good morning, Perna. Always very polite. Look forward to your good mornings.
So I'm looking at the relationship of the P and the QRS complexes here.
Mm-hmm.
Just give me one moment. Let me look through the.
Please take your
Yes, sure.
time. You're allowed to take your time. I remind you in the boards, you'll have approximately 30 seconds per question.
So I'm looking at the rhythm strip, and there is a pacing spike after every P wave. Just before every QRS. So I would imagine this is also A-sensed V-paced.
That's correct. That is true. Now I'm going to ask you the Sunny Duong question, which is this unipolar or bipolar V pacing, do you think?
This does look like, the pacing spike here does look like it's pretty large. So I would call it unipolar.
Yeah, so just again, to show you in the prior image, why this is like so slow. Okay, so, right. So in the prior image, we see these very small spikes, whereas in this is what a typical unipolar pacing spike looks like, and this is at the same 10 millimeters per millivolt. So can you give me 2 reasons why somebody might be unipolar paced? I just explained that we would prefer it in a perfect world that everybody have bipolar leads. Why do you think it is that someone might have unipolar pacing? And are there any advantages to unipolar pacing?
The pacemaker is old, I guess.
Okay, so not necessarily the pacemaker, but the pacemaker lead. So this could be some ACHD patient who had these leads put in 1992, or, you should know that until until the 1990s, early 90s, they were not really bipolar transvenous pacemaker wires. So, and most of the thinner wires were unipolar. I remember when I came to Columbia in 1998, as the electrophysiologist, I inherited a very large number of older patients who had unipolar pacing systems, transvenous pacing systems, because the surgeon who placed pacemakers at that time liked this then five French lead made by a company called Intermedics, which was ultimately bought by Boston Scientific, that was steroid eluting and had reasonably good track record for longevity, but it meant that everybody was unipolar paced. It wasn't until, well, at that time, around the late 90s, they finally more regularly had bipolar transvenous leads. So this could be a person who had a very old pacing system. That's one possibility. What's another reason why someone might be, is there any benefit to being unipolar paced?
Mm.
I mean, it makes it easier to read the EKG. Spike.
I don't know if there's.
So one of the
Any specific-
advantages of unipolar pacing is that in general, on average, thresholds for pacing are lower when you pace unipolar.
Mhm.
That's not obviously always the case, but as a general rule, it is true. You may remember that in our patient with hypoplastic left heart syndrome, or maybe you're not aware because you weren't on service, we had problem pacing the atrium with our leads, and we actually placed a skin lead. And so when we place a skin lead, we are essentially hoping that one of the two leads that are on the heart are working, and we assume that one of them is not. And so the skin lead basically was a new ground. And so when we put a skin lead in, almost by definition, we are effectively unipolar pacing between the electrode that is on the heart and the reference electrode, which is in this case in the skin. So, and one of the reasons it works is because unipolar pacing generally has a lower pacing threshold. The other reason we could be unipolar pacing is most pacemakers in 2022, and for many years now, have a safety feature where if they observe an impedance rise above, say, 1,000 ohms, or in most cases, 3,000 ohms, the system will revert to unipolar modality for pacing on the theory that the pacing threshold will be lower, and that, if there's a problem with the insulation. So one possible reason we could be unipolar pacing in this case is that the patient's lead, which may have been bipolar, may be partially broken. And so we're taking advantage of the electrode that is still touching the heart and using unipolar modality in order to achieve capture. The other possibility is that, they do sell unipolar steroid-eluting epicardial leads. When we, in babies, have the surgeon place an epicardial system, typically they're placing bipolar electrodes in the A or the end of V, or only in the V, but they're almost always bipolar electrodes with two pods, but they actually do come as single pods. And for patients who are very, very small, it would not be unusual in the old days, and don't see them used almost ever anymore, but those unipolar leads worked quite well. But of course, if they were to break, then you would be left with no pacing at all. And as we've discussed many times in the past, epicardial systems, as a general rule, have a tendency to break with a greater frequency than bipolar systems. The other thing to note is that I remember not that long ago, the group from Michigan published a paper in which they compared the longevity of bipolar steroid-eluting leads to unipolar, and they found that on average the bipolar systems lasted longer, and that was really because they had the option to revert to unipolar in the event of one of the leads breaking, or one of the pods of the bipolar breaking. And so that, by definition, and I've taken care of many patients who are being paced unipolar through epicardial leads, it's always a little scary because you know that one of the pods has already broken and you sort of have nothing left. So in a perfect world, you would want a patient like that to have a reasonable escape rate in case the other lead were to break, or the other pod were to break, or bipole end. So anyway, so I don't know, I don't remember. Let me ask you this, Perna, can you tell where in the ventricle this pacing lead is? Let's start. Is it in the right ventricle or the patient's left ventricle?
I am going to say right ventricle.
I agree with that statement. How did you determine that?
The pacing spikes are, I see them like in V2, V3, it's like the tallest.
Okay, that's an interesting observation. I'm not aware whether that's true or not.
That's a
So you're
good-
saying because the spikes are larger in the rightward side, I don't actually think you can do that, but I've never heard that. What about the
I'm just-
morphology of the QRS? Is this a left bundle morphology or a right bundle morphology?
Yeah, left bundle morphology.
The left bundle morphology. So it is actually, so that would suggest that we're RV pacing. And by the way, this is one of the important reasons why it's important to do a 12 lead after someone has had a pacemaker implanted. You know, sometimes after a patient has a pacemaker, we admit them overnight and they're on a monitor. And so when we ask for a 12 lead, you may wonder, well, you know, you have documentation on the monitor that there's been appropriate sensing and pacing all night. Why do you need an EKG? One of the reasons is you want to confirm that you're doing RV pacing. Can you tell where in the RV this is?
No. Can't.
Well, the QRS is negative in 2, 3, and F. So presumably the impulse is moving away from that location, suggesting that the lead is probably somewhere in the, maybe in the RV apex or at the bottom of the right ventricle. In a perfect world, we should be septal pacing down there. So this suggests to me that the lead is in a traditional standard location. And as we've discussed a number of times, and so it's in a safe position, and this is the position where we would expect the greatest stability, the least likely chance of the lead moving, but it is also the position that is associated in general with the worst ventricular function. So interestingly, the most common location we put pacemaker leads, which is the RV septal surface towards the apex, is actually the area where if you do, you know, people have studied this. There is no exact sweet spot in any patient. Every single patient has a different best location for their lead in regards to cardiac output. That's been shown in a lot of different studies where people have done pacing studies with cardiac output measurements. But for sure, if you look at all studies, almost universally, the single worst location in terms of output is placing it exactly where we most commonly place it, which is the RV apical septum. And so you might ask the question, why do we do that? And the answer is because we don't want the lead to embolize. But in truth, I think with time, we're going to start pacing different areas, but we're going to have to accept a greater incidence of lead dislodgement and embolization, which is a real problem because when you reopen a pacemaker pocket within the first 6 to 8 weeks, the risk for an infection is extremely high. It could be like 10 or 15%. So you really kind of want to get it right before you close that pocket, because you don't want to have to go back in there. And so I think that when we consider the grave consequences of a pacemaker infection, as a general rule, most electrophysiologists would prefer just to have a safe implant, even if the optimal location is not where we're putting the lead. But you know, you may have done some reading or seen in the literature, there's an increasing reliance in the adult world on His bundle pacing. So they put the lead in the septum near to the His, and they can get a fairly narrow QRS complex that looks almost like a conducted beat, and that has been associated with improved function in some patients. In fact, some believe it is as good or better than so-called biventricular pacing. There also is left bundle pacing. So one of the problems with his bundle pacing is that because the area you're screwing into is fairly high in the septum and somewhat unusual location, there was a fairly high incidence of lead dislodgement. And also the threshold to pacing at that area can be very high, meaning that you'll deplete the battery fairly quickly. And so in response to that, adult electrophysiologists have come up with a technique where they essentially screw into the septum near to the His very deep until they're capturing the left bundle. And that has been demonstrated in a number of studies to be essentially just as good, maybe even better than His bundle pacing. And the likelihood of lead dislodgement is much lower because you're really screwing it quite aggressively into the septum. One of the concerns that has been raised about this approach is if a patient were to become infected, it would seem that that would be a much harder lead to extract or remove. It's also very difficult. You have to really get very deep in the septum in order to capture the left bundle. And so it's not technically that easy to do. But I do think that the days of just throwing it in the apical septum probably are going to become less common over time as we learn more about function. Now, the reason we get away with it, of course, is for the reasons that we've discussed in the past, which is that patients who have normal function do not get a very substantial increase in cardiac output from these different locations. It could be, in the range of about 5%. However, over long periods of time, it could be an issue. And also the incidence of pacemaker-mediated cardiomyopathy probably is higher if you put it in the wrong location, such as this one. But this would be considered a standard nice EKG from someone with a unipolar V pacing lead, although practically it probably is not the optimal location. Let me go back here. Okay. So this is an A-wire tracing that was recently obtained on post-op night number 1. And the question is, what is the rhythm? How would we confirm this? And what do we want to do about it? And I think I'm going to ask, Dr. Bebbia for his thoughts on this.
Good morning.
Good morning.
So I see a heart rate of 150 approximately, narrow complex tachycardia. And I don't see any P waves before the QRSs. So I would
Yeah, I'll just remind you, this is an A-wire tracing, just so you know.
Oh, you're right.
So
right,
I
sorry.
believe, whoops, sorry. So I
Yeah.
believe, sorry, this, I don't know why this, sorry about this. I believe that the top and the bottom leads, I think actually the top is the A-wire tracing.
So the second lead is the regular.
I think
EKG
the
lead.
second lead is lead 2, yes.
Lead 2. All right. So then we see that there are no P waves before the QRSs. So yes, I would say it's junctional ectopic tachycardia. I would like to compare this to a prior EKG before this tachycardia started to compare the QRS morphology to be sure.
Unfortunately, the patient didn't have one. This is the 12 lead of the same patient, in case that's of any help for you. Now, what is the definition of junctional ectopic tachycardia, since you invoked that diagnosis, which I'm not disagreeing with, but
well, it's a tachycardia originating from the AV node.
the His bundle, but yes.
His bundle.
Same idea, yeah.
Which is common in the early post-operative period.
What's the most common surgery that causes junctional ectopic tachycardia? Where do we think that we get that injury usually? in what operation? Like if I said to you, which operation would you most likely expect to see jet if you were going to see it in? Which ones would that be, or which one would that be?
I would say either tetralogy of full repair or VSD repair.
Yeah, that's certainly true. Okay, so clearly I agree with you. This is not a sinus rhythm. How would you know, though, that this isn't, this could also be VT, couldn't it? I mean, you have,
Right.
it's a narrow QRS, but it's a young patient. Young patients can have narrow QRSs. Is there some way that we could look at this rhythm, or is there something we could do at the bedside that would be able to, so just to go back to the A-wire, I think that I agree with you. This is probably the atrial electrogram, which is essentially on time with the QRS. So I guess it's possible. So this could be VT, right? Or it could be junctional ectopic tachycardia. So junctional ectopic tachycardia, the point I was trying to get at is really any junctional rhythm which causes hemodynamic embarrassment. Now there are, if you read in a textbook, they'll sometimes say the rate over 170 or 175. That probably, you know, I would say that rate is perfectly reasonable to say, but I would also say any junctional rhythm that causes hemodynamic embarrassment. Now, in this case, this was in a patient with hypoplastic left heart syndrome who had a Norwood operation. So if you were thinking about that operation, what part of the Norwood do you think was the part that could have resulted in a junctional ectopic tachycardia for our patient? There's
The
no
atrial
VSD, there's
septum
no
incision.
VSD. Yeah, the
Yeah.
atrial septectomy would probably be the, you know, not being a surgeon, but that would probably be the part of the operation I would have imagined would be the most likely, right? Because the components of a Norwood are an atrial septectomy, an arch reconstruction, and placement of either a Sano shunt or a BT shunt. So if this patient had a Sano, you could imagine that maybe that would be a cause of junctional ectopic tachycardia, but we know that our patient had a Blalock-Taussig shunt, and so Blalock-Taussig Thomas shunt, I should say, and so that that does not seem likely to be. So it's probably the atrial septum,
Yeah.
you know, and so okay, so you have this rhythm here, and we've decided that this is likely not sinus because the P wave is on time with the QRS. The QRS is narrow, so that's suggestive of it being junctional ectopic tachycardia and not VT. And the QRS morphology and axis are similar to that we would expect in a young child. But is there some way that we could firm up this diagnosis and definitively rule out VT as a diagnosis here?
Sure, we can pace the atria and see if the QRS morphology changes. And
Right.
we need to pace obviously faster than the junction.
So if we pace the atrium and the morphology were to change, what would that mean about this rhythm?
VTAC.
VTAC. So in fact, our outstanding cardiology fellow did just that. And what we see is, in fact, that the QRS morphology is exactly the same as in the spontaneous rhythm. Here's spontaneous, and here is a paced rhythm. Okay, so now we're apacing and everything looks good, and blood pressure is better. The lactate is starting to fall, but is there anything, so how are you going to treat this? So then the tachycardia accelerated in this case. So what are your options to managing this, Sergey? This seems to come up every single time.
Yes, so our strategy would be to cool the patient, try to come off the inotropes, sedate the patients, and then use antiarrhythmics, which we usually choose between procainamide or amiodarone I guess that would be our most common choices.
That's right. And now, in this particular case, we chose to use amiodarone. And the reason I chose it is mostly because it's been my impression that our surgical colleagues have a little bias towards amiodarone. Now, I think those of you who've been involved in the care of this patient would agree that although the amio helped to slow it, it wasn't a panacea by any stretch. Actually, we had to give like we gave a 5 per kilo bolus, and then I think we gave 3 or 4 3 per kilo boluses over the next 6 to 9 hours, and still were in rates of, the 150s to 160s. The other interesting thing that happened is, so we see here that we are apacing and conducting 1-to-1. So what would be the advantages of amiodarone versus, say, cooling and procainamide?
Besides that, you don't need
Other,
to
other
cool.
than the fact that the surgeon likes it and you won't have a fight with with surgeons. But what is the advantage of that approach? If you were an amiodarone salesman, what would you say is the reason you should use their agent?
First of all, you don't need to cool the patient.
That's true. So you don't need to cool the patient. And so in theory, you could, if it works well, you can get the patient towards extubation a lot faster, right? Because you can't extubate somebody who's being cooled to 35 degrees, which is typically what we would want if we were using pro. Any other advantages to amiodarone? I mean, I'm not actually aware of any. What are the disadvantages of amio?
Well, there are side effects.
Uh-huh.
And
What are the side effects that are of concern?
hemodynamic instability, hypertension.
Right, it can cause,
if
it can
we-
even cause cardiovascular collapse. Although generally speaking, if you give it very slowly, you can usually identify the problem before it happens, but sometimes not, and it can sometimes do that. What other disadvantages are there to amio?
And I mean, the long-standing complications, the thyroid dysfunction.
Okay.
Um,
It is a concern, but not usually very important one when you're trying to live after a Norwood. But yes, I agree that long-term, it's not a great, it has some risks with the liver and can even affect your eyes, right? What other problems can be acutely associated? So we talked about the hypotension, but hypotension can also happen with procainamide also, right? Can cause
Sure.
vasodilation and hypotension. What is the effect of amiodarone on heart function? It's actually a pretty potent negative inotrope. It's interesting. When it was first introduced, it was introduced as this great drug that had almost no direct cardiac impact, but actually experimental data suggests that amio is a fairly potent negative inotrope. So it is not, great. And then what about if you give it peripherally? Any concerns with giving it peripherally?
Oh, yes, it can damage the peripheral veins.
Right,
easily.
it can cause, right, you can get vein
Sclerosis,
sclerosis
right.
and you can get chemical burns from it potentially. And then there's also one very important side effect, which is something that we encountered in this patient, which is that amiodarone, what does amiodarone do to the AV node in general? Does it cause improvement in AV node function? Does it slow AV node conduction, or does it have no impact on AV node conduction?
I would say it slows the AV conduction.
It does. It can have very important impact on AV nodal conduction. And in fact, in this tracing, which was obtained before any medical therapy was started for the junctional ectopic tachycardia, we see that we're conducting 1-to-1 at a rate of about 150 beats per minute. Once amiodarone was started, we could no longer conduct at rates above about 150. And so we were forced to AV pace this patient rather than A pace. What's the downside of having to AV pace somebody versus just A pacing them?
Well, I guess you can develop pacing-induced cardiomyopathy faster.
Yeah, but that's something that happens over 20 to 40 years. So, I mean,
Not that fast.
what I'm trying to get at is that V pace, you know, as a general rule, your cardiac output is probably going to be better if you can conduct in a normal length through your PR, through your AV node with a normal PR interval going through your AV node versus V pacing. V pacing in general never is as good as conducting yourself unless you have a very, very long PR interval. And so almost by definition, if you have to V pace, you probably are going to lower cardiac output to some degree. But in the setting of JET, if the choice is between being junctional at say 155 or being AV paced at 160, usually, not always, but usually you'll have better cardiac output if you are AV paced rather than just A paced. Or I'm sorry, rather than being in junctional ectopic tachycardia. It's not always the case. It's always worth sort of assessing the hemodynamics after you've made any kind of change like this. But in fact, we sort of got all the bad things about amiodarone and not too many of the good things. We did get a little hypotensive with it and had to actually come off of a lot of, this patient was on a number of antihypertensive agents prior to the starting of amio, which all had to be removed initially. This patient developed block at these types of rates and had to be AV paced. And most important of all, it didn't really work very well. The patient was basically constantly, we were fighting with this rhythm until ultimately the natural history of it won out and it's sort of stopped on its own. But so it did work well enough that we got through everything. Our lactate levels fell through the night. The patient was better in the morning, but the amio took a long time to work. And even in the morning at like 7 o'clock, we were still rebolusing amiodarone. So had I to do it again, I would have certainly used procainamide. One of the reasons I didn't want to use proc was because, first of all, I knew that our surgical colleagues are not big fans of it. I'm not really 100% sure why. If anything, it works almost too well. The other reason I didn't want to use it was that the faculty in the ICU wanted to use it without cooling the patient. Like the patient was not cool. The patient was like 36 degrees. And really, procainamide only works for JET if the patient is already pretty cold. And you know, it's very difficult to keep an infant at the correct temperature. You can put them on a cooling blanket, but you have to continuously monitor the temperature because you can make a patient, you can overcool a patient. What's the downside of overcooling? So let's say you're shooting for 35 and you end up at 33, which can happen actually, and I've seen happen many, many times. What would be the danger of that, Sergey, if the patient was down to 33 degrees accidentally from a little bit of over-aggressive cooling?
It causes shivering, and hypothermia causes acidosis.
Yeah, no question. Those are both very, very bad. But let me tell you something. 35 does the same thing. 35 also is very uncomfortable. I'm sorry?
They can arrest.
They can arrest. That's right. You can have VF. In fact, when they go on circulatory arrest or when they go on pump, they routinely cool the patient, right? But they don't care if the heart stops. They want the heart to stop, but we don't. And I've told this story many times that when I was a resident at Cornell, I was reading about junctional ectopic tachycardia in the NATIS textbook. And one night I was on call and we had a post-op TET and the patient had JET. And actually, I was the only person who figured that out. Like the attending on call who wasn't had no cardiac background. I basically told them that's what I thought it was, that I had been reading about that just that week. And I showed them the chapter in the book. And then I called the cardiologist on call, who was this very nice older woman named Kay Ehlers. And Dr. Ehlers, I faxed her the EKG because that was all we had then. And she agreed with me. And so I had read that it just said cool the patient. So I gastric lavaged the patient with ice water. And we got the temperature down to like 32 degrees, and we had beautiful sinus rhythm in the morning. Everybody, was impressed by this. But in retrospect, that was really dangerous. I didn't realize that like I was overcooling, and at any moment the child could have had VF. Also, we never ice lavage the stomach anymore because it can cause terrible electrolyte abnormalities, because you're basically putting free water into someone's gut, and you have no idea if what's going to happen to the electrolytes. So that was in my defense, there were no cooling blankets then, but it really was very, very dangerous. When I was a medical student at Mount Sinai, visiting in Mount Sinai, Dr. Rossi, who ran the ICU, I saw him treat Jet by literally taking an ice bucket and pouring the ice all around the chest and the abdomen of the patient. Had an open chest, and I remember it was very dramatic. He took this ice and was like pouring it around the patient's body. And that's how they cooled the patient then. And honestly, that was how I decided to, one of the first times I thought about becoming an electrophysiologist, because I just thought it was very dramatic and very cool. It actually did work, but it was probably, very difficult to control temperature in that manner. So in this case, we used amio, and actually the literature suggests pretty strongly that amio is not as effective as some would believe for the treatment of junctional ectopic tachycardia. It does work, but it is not very fast or good. I'm actually on the pharmacy committee for pediatrics, and I am trying now, we're slowly going to work towards getting IV sotalol on formulary here, which has been recently touted as a good way to treat Jet that does not have very much impact on blood pressure and seems to work faster in very small preliminary studies. So probably worth at least giving it a try in a couple of patients. It seems like it seems that it does work faster than some of the other agents, but again, these are in studies with less than 20 patients, so it's really hard to say for sure. But thankfully, because this is a self-limited disease, eventually it got better. The patient did well too. Any questions on this? Okay, so I think with that we'll stop, and thank you very much for joining. I'll see you at 8 o'clock at sign out, and hope you all have a great week. Speak soon.
Thank you.
Thank you.
Bye.